mainly around data collection for evaluations and the information governance that goes around that as well. So just a quick agenda, looking at what is baseline data and what do we need it for. Key stakeholder considerations when we're thinking about data and what data we need to collect. The PICO framework that can help sometimes frame what you're trying to articulate as part of this. Okay, sorry, Teresa's put a message in. The evaluation data that you need to think about and the metrics, information governance, which is a big thing and can take quite a lot of time when we're looking at real world evaluations. External sources of data, a potential upcoming change which might impact on real world evaluations going forward. And just a quick recap, there's also some resources at the end for you to have a look at when I send the slides around. It's not working now. Okay, so what is baseline data? Baseline data is the data that allows you to look at the current state of affairs. So where the current clinical pathway is, what sort of turnaround times, things like that, that you'd be looking at. And it can help evaluators identify potential opportunities and issues that might arise as part of the evaluation. So it helps you almost to plan ahead a little bit to some potential things that might pop up. And it also allows you to measure any variation in your chosen pathway, which probably might not have been apparent during clinical trials when everything's really tightly controlled. So it allows you to look at maybe sort of seasonal variation if that's an issue, or user errors, things like that. And the data will effectively be the benchmark that you will measure your innovation against. You need to show some sort of improvement on your chosen metrics against that data. Another thing to think about going forward is your key stakeholder requirements. So what sort of narrative do you need to be providing to your key stakeholders for this to be adopted, for your innovation to be adopted? And different stakeholders obviously want to see different outputs from your evaluation, and you need to really try and tick off as many of them as you possibly can. So clinical staff want to see evidence of things like efficiencies, the accuracy of what you're putting into their clinical pathway, especially in terms of sensitivity and specificity, if that's applicable to your innovation, patient safety and user safety. So obviously they don't want it blowing up in their faces or something like that. Impact on their workflows. So they want to see their workflows being made easier rather than more difficult. Ease of use for the technology that you're trying to implement, and patient acceptability if that's an issue as well. Patients, if they're a key stakeholder, especially if this is something that you're wanting patients to buy or to use frequently, they want to know that the innovation that they're using is safe and effective, so it's actually doing what you're telling them that it's doing. They also want to know about any side effects, especially if we're talking about therapeutics and pharmaceuticals, and how usable and accessible is it, especially if we're talking about digital technologies. And the payers want to see evidence, especially if it's a trust payer or an ICS. They're mainly looking at things like cost savings, or at least at the very minimum that it's cost neutral, so you're not adding extra cost onto the system. They also want to know that it's safe, but they also want to look at the wider implementation stuff, especially around training and logistics. So if it's something that you need to move around quite frequently, how are you going to get that done? They would like to see increased productivity as well. Need to think about interoperability with current IT systems, things like that. Information governance is a big thing for them, and the product life cycle. So how much money is the trust going to have to spend maintaining this equipment, etc., things like that. So when we're considering our baseline data, really the best place to start is getting your current clinical pathway mapped out as far as you possibly can. This was discussed in webinar 1, but usually a good place to start looking for things like this is NICE, or speak to your clinical partners. They should be able to help you map that out, and you can start seeing as part of that where potential bottlenecks are and where the big cost points are. And if you can start addressing some of those, that's always helpful. It can also inform what data is potentially there to be collected and who can collect it for you. We've already discussed the narrative that we're trying to create. What benefits, efficiencies are you anticipating? And then what metrics can you then collect to prove that narrative? And who is your narrative aimed at? Like we've already said, different stakeholders want to see different things. So we want to try and tick off as many of the long list as we possibly can. Another consideration is there actually any baseline data for you to collect in the first place? If you've got a completely novel pathway or a completely new technology that's going to totally change the current practice, you might not necessarily have some baseline data to collect to start with. And you need to show that you've pretty much done as much due diligence around that as you possibly can, that you've looked at all the available options, and there definitely isn't any baseline data. And another thing to think about is, what are you actually collecting all this data for out of the evaluation? Is it for a nice submission, in which case you'll probably need a lot of data and it will need to be very robust? Or are you collecting it for a business case, for a local business case, in which case it could probably be a bit more pragmatic. You can put weave a lot more assumptions into that, and you can make it a much tighter narrative, which is always a lot easier. The requirements for both can be very, very different. And especially if you're going down the NICE submission route, I would definitely recommend that you go and get external support, either from an AHSN or from NICE themselves. They'll be able to tell you what sort of thing you should be looking at for that. A good place to start as well is what metrics are actually easily available now. So what can your clinical partners pull up quite easily, and what will need input from elsewhere? So do you need to go and look at some external databases? Do you need to go and speak to informatics? Do you need to go to NHS Digital to get national data for this sort of thing? And also, are you collecting qualitative data from staff and patients? While this sort of data is very difficult to put a cost against, it can actually help the narrative that you want to put forward, and it can actually be really useful. So you need to think about how you can safely collect that sort of data, and are you going to need ethics approval for approaching patients for this sort of data? Again, your clinical partners should be able to advise whether or not that sort of thing is required, because it can vary from trust to trust. Some trusts are quite happy with you sending anonymous surveys out to patients, well, as long as the clinical staff send it out, whereas others would rather go through ethics for that sort of thing. So you just need to check site by site. Another good way of framing your narrative as you're going along is to use the PICO framework. And it's really helpful to start with when you're sort of pulling various bits of information from various different places. So if you can populate this sort of framework as you're going along, it just helps sort of stop you drifting off target. So you really need to think about your population. So who's going to benefit from this? And that's not always necessarily patients. So patients are usually a big part of it. What clinical staff are going to benefit from it? Are we going to benefit operationally, etc., things like that? So don't think just about patients. And is the target population similar to the population that your target service is already delivering healthcare to? So are you actually putting this intervention in the right place, and are you targeting the right population? And you quite often need a very clear narrative about your intervention. So what is the innovation that you're putting in place, and what is it actually meant to do? And this needs to be explained in a way that's very easy for people to understand, especially for bigger tech things that are quite complex. So you want to try and run that sort of thing past somebody who isn't involved in the technology and see if they understand what you're trying to put across. And you need to have a very clear narrative about what change this innovation is actually going to bring about in the pathway, and what are the implementation requirements for getting it into routine use. Again, that's things like training, equipment servicing, etc., things like that. We've already talked about the comparators, so what's currently happening. So a really clear description of what's currently going on in that space. And you quite often need a good awareness of what also is available on the market, especially once you take this to procurement. So what could people use instead of your innovation? Because that generally tends to help if you're trying to get it past a single tender waiver or something like that. You know, you can say, this bit of kit is very similar to what I've already got, but mine's different because I can offer you X, Y, Z and the other that the others can't. And they will go and check that, so don't try and plug it. And the outcomes that you expect from this sort of evaluation, and they need to be very definitive. So you need to be able to clearly state what you expect this intervention to do, and what are the impacts on patient care, clinicians, wider services, things like that. So if you can explain the potential impacts of services beyond yours. So for example, if you're putting a point of care into A&E, that will have ripple effects further down the line. So if you can show some awareness of what those impacts are, that really helps get some traction when you come to a business case. So when we're looking at evaluation data, the data that you're collecting as part of your evaluation need to be as closely aligned to your baseline data as possible. So you're comparing apples with apples. And if, as far as possible, try and automate that collection. So if you've got something that will integrate into the NHS systems, IT systems, and they'll let you integrate for the sake of an evaluation, try and get as much data out of that as you possibly can. Try and get as much data out of an app or AI or whatever it is that you're trying to implement as you possibly can. And also look at other sources, like I say, informatics, things like that. You really want to try and take as much of the effort off your clinical partners who are doing the evaluation for you as you possibly can. They've got other clinical considerations to think about, and quite often getting this data for us is secondary to that. And you could also consider measuring the process instead of the output. So if you're trying to put something in where your patient outputs, for example, are 2, 3, 4 years down the line, but you know that those outputs are pretty much guaranteed as long as the process is followed, you can measure the adherence to the process instead of doing a 2, 3, 4 year evaluation and measuring the actual outcomes. It takes a little bit of twisting when you come to the health economics and quite a few assumptions, but I think it's usually well accepted if you can justify why you're going down that route. And if you're looking at qualitative data, so things like questionnaires, surveys, etc., allow longer for that process than you think you're going to need, again, because you might come up against ethics, and that takes a while to go through. But these things do actually take quite a while for it to get a good response rate. So if you're aiming for a certain number of responses, try and give yourself a little bit longer if you possibly can. I'm sure Flora will agree with me that it can be a bit of a pain to get these done, that they're well worth doing, but they always take longer than you think they're going to take. And another thing to think about is potentially any additional administrative resource to gather data that you can't collect through the intervention itself or through informatics, things like that. You potentially need to think about paying for backfill for administrative time to get that done. And again, I'd allow longer for that than you think you're going to need, because again, they've got clinical demands and they will always come first, regardless of how much backfill time you're paying for. Evaluations will always come secondary to their actual day job. And also, if you do actually require data from informatics, you need to engage them as soon as you possibly can in the process, because you need to partly get it booked in with them in their scheme of work, because they've got other things to do as well, but they can give you a really good indication of what you can get through them and what you need to collect elsewhere. You'd be amazed at how much you can actually pull out of informatics if you ask the right questions and you give them the right spreadsheet to populate. So the actual metrics that you'll be collecting for this will obviously vary quite a lot depending on the setting that you're putting it into and the technology that you're evaluating. But really careful consideration needs to be given to what you are collecting, especially the process of it, because if it's too arduous or just too time consuming, you're not going to get the right data that you want. The data's sort of usually half completed or sort of done retrospectively, which is not really what you want. You want data to be collected as it's being used, because it's much more accurate. And if you're asking clinicians to collect data for you manually, you need to make the data collection form that you're giving them as simple to fill in as possible. I've seen evaluations where you've given clinicians sort of like 2 sides of A4 to fill in for bits of data, and they just will not do it. They have not got time to do it. So try and make it as simple for them as you possibly can, and try, if you can, not to lead them to the sort of responses that you want. So we've had evaluations in the past where there's been some poor phrasing on the collection form, and the clinicians using the technology have selected patients to use the technology on to give us the response that they think we want. So it's really simple to do, because you're putting these together with the expectation that that's the data you're going to get. So you need to make them really as simple as you possibly can, and be guided by your clinical partners on what's actually achievable and what's realistic, what data's there and what isn't, and what you can get hold of quickly, especially if you're looking at something that's you need to get done quite quickly. Some external health economists also have access to national databases. So if you go somewhere like York Health Economics Consortium, they've got access to tons of national databases that I definitely do not have access to. And they'll be able to obtain data for you that you probably can't collect on site. So they're always good to go and approach if you need something like that. So once you've got a rough idea of what you need and what you're collecting, I'd make a clear list of all the metrics you're going to collect and who's going to get them, where from, and when you need them by. And you need a clear justification as to why you need each piece of data. It would also be really helpful if you could map out the movement of information between partners. So if, say, for example, information's going from a trust to an AHSN to an external health economist, you need to map who's going to be touching that data at each point, because you're going to need that for information governance later on. So once you've got all the data together, you then need to approach your information governance leads at the trust or the sites that you're looking at. Most trusts do have their information governance policies on their websites and their main information governance contacts. You might just have to go and do a bit of digging. But they're always the best people to approach at the beginning of a project. They should provide some kind of support and guidance through this process for you. As a bare minimum, you will need to complete a data protection impact assessment, just to sort of go through what data you're looking at and whether or not it has impact on data protection laws, really. They're usually super simple forms to fill out, about 5-10 minutes tops, if that. But if you're looking at something more complex, where data is actually going to be, like patient data is going to be leaving the trust, you will need to complete a data sharing agreement. Those documents can be a bit laborious to complete. I know Oxford University Hospital's one is ridiculously long, and that they can be quite complex if the data movement is complex. So make sure you leave ample time for that. Again, information governance guidance could be provided by your local AHSN or the clinical site's information governance lead. Once you've completed all the required forms, they'll need to be submitted to the trust or clinical site for approvals and sign off. This is quite often a bit of a black hole. You sort of send them off to your named contact and then they disappear into the trust to be signed by at least 4 people. And you can never tell where it is in the process. It takes quite some time, so make sure you give yourself plenty of time to do it. And they do sometimes ask you to make amendments, so the forms can go backwards and forwards quite a few times, just for you to make it clear really what you're trying to do. I've yet to see one of these forms come back rejected, so it's usually just tweaking it to make it understandable for the trust what you're trying to do. And data collection shouldn't really commence until you've got this signed off, but if you want to get a head start, you can ask your clinical staff to start gathering some of their baseline data. They just can't share it with you. But I didn't tell you that. So potential sources of your baseline and evaluation data. There's numerous places you can get data from within a trust. There's clinical audit, like clinical unit level audit data, so things that they're just naturally collecting to report back to NHS England on. The amount of information varies quite widely from speciality to speciality, so it's always worth looking at that first if possible, just to see what the clinicians are already measuring as they're going along, just see what you can use out of that. And it's quite often a good source of baseline data, even if you have to top it up with other things, but it's a good starting point. There's electronic patient records, and that data is usually accessed via informatics. The amount of data taken from patient records needs to be considered really carefully, because we have the Caldecott principles to consider. They're available online if you want to go and have a look at them. I'm not going to put them up now. And you need to be able to justify very clearly in your information governance documents why you need that information. But that sort of information can be really useful when you're looking at costs associated with healthcare utilisation. So we're looking at sort of like reduced length of stays, reduced A&E visits, things like that. And by the time the data leaves the trust, it should always have identifiable patient data removed. So you shouldn't see NHS numbers or MRN numbers or anything like that. It should, and maybe have a patient identifier against it so you can track them through the system if they crop up more than once in the data, but you shouldn't be able to link it back to the patient records. Laboratory systems have quite a lot of information as well. They're really useful for point of care testing, things like that. So the amount of data that you'd need for that sort of thing. And then there is data collection, which is actually collected at the point of use for your innovation. So logbooks for results may need to be considered for things that can't actually be linked into the hospital systems for the sake of an evaluation. So we've evaluated quite a few bits of tech over a 3-4 month period, and that the trust IT systems just turned around and gone, it will take far too much work for us to integrate it for you, so then potentially have to take it out again. So you would have to look at having a physical logbook or something like that next to your innovation to log the information that you'd need to get. And again, you'd need to think about who would have access to that and how to keep that sort of data safe. If we're going outside of a trust, data collection can be a little bit messier, and there's quite a lot of change going on in this space at the minute. I know Oxford has a primary care data lake, for want of a better term, which is accessible for researchers. I'm not sure if other regions have something similar. Things like that. So you just have a scout around and see what sort of local databases are available. GP practices can also share data from their electronic patient records. Again, all your patient identifiable data will be removed, but obtaining that information is like really laborious, because more often than not, you've got to get admin staff to manually go through everything for you and to pull out what you need. So backfill will definitely need to be considered for things like that. Patient registries are also available for certain conditions, but again, the amount of data collected in these registries and the quality of it is quite variable. So you just want to have a check for your certain conditions to whether the registry has the information that you require. NHS Digital also has various databases available. They've got data collections, past like historical data collections broken down by clinical area, and they've got data access environments. So areas where you've got secure access to data. You can't remove that data from the NHS Digital system, but you can go in, you can have a play with it, you can get a feel for what's going on. And as far as I'm aware, there is a cost attached to that, but I'm not sure how big a cost that is. Your local HSNs or contracted health economists, something like that, will also be able to advise on data availability and access, because like I say, it does vary quite a bit by region. There is an upcoming change that potentially will impact on real world evaluations. So I think it was last September, trusted research environments were announced, and they're currently in development at the minute. So they're very similar to the NHS Digital current secure environments, but everything will be in one place. That's the current hope. And they will be the default place to go to access NHS and adult social care data, which will be de-identified. At the minute, they're saying it's for research, but there's no news yet on whether it will extend into the evaluation space or if it's purely pre-regulatory research. If it does extend into the evaluation space, I think it could cause some potential issues, especially for things like health economics, when you can't take data out of the system, but we'll have to see how that pans out. That's currently in development and in consultation at the minute. Accessing that data will also have a cost attached to it. They're potentially looking at a couple of models at the minute where you either pay up front for the data or you do it on a licensing agreement. Again, they haven't quite worked out how they want to do that yet. So just a quick recap. Baseline and evaluation data needs to be very carefully considered. It can include quantitative and qualitative data. And again, the qualitative data might have some ethics approval attached to it. So just allow a little bit of time for that sort of thing. Try and take the bare minimum amount of patient data that allows you to achieve your aims. You're more likely to get information governance approval for that sort of thing. And there are numerous sources of data available on a local, regional, and national level. You sometimes just have to go digging a little bit for them. But there are some people around who can signpost you to things. DPIAs and data sharing agreements are required and will likely take longer than expected. So we also need to consider that as you're going along. There's some resources that you've got access to. So when I send this round, along with the announcement on the trusted research environments, you can go and have a look at that, keep up to date, see where we're going with that. Any questions? Sorry, that was a bit of a whistle-stop tour of data that isn't available. So. Does anybody have any questions? You should be able to unmute yourselves. Oh, hang on.
I don't have any questions, but I might be able to answer some, since I actually am one of I'm one of those informaticians that happen to work inside a clinical department. Rather than for corporate IT, for OUH. For OUH, so perhaps I probably shouldn't have volunteered, but if you have any, I mean, from what you've said, I can endorse exactly 1000%. That's absolutely on point. But if folks have any questions from somebody on the actual inside, I'm happy to take them if that would be useful.
Thank you.
Yeah, Grant, it's Tony Kilbourne here. Could you, I've never come across anyone from informatics before. What do you do? Where are you based? Sort of what's the structure?
So, okay, so the trust has its own informatics department, corporate IT, the information team. So they are basically set up to answer mostly corporate level informatics questions, and they sometimes might help individual departments, for example, extract data from some of the big systems that we have. I'm different. I don't work for corporate informatics. I work for the Department of Clinical Hematology. And I basically provide an internal informatics service for our department. I do also work a bit more broadly within our directorate, so for oncology and sometimes up to and including divisional level. So yeah, I'm odd. There are not many, as far as I know, there's not many of me around an OUHFT. So unlike the corporate, my primary focus is on basically our clinical data and understanding its provenance, what we can get, what we can join, how reliable it is, and then gaining actionable insight. And then every now and again, I might create applications and stuff to help improve information flow or to automate data collection and do other things like that. Does that answer your question?
Yeah, sort of. Yeah, no, that's helpful. Thank you.
What are you missing?
What do you need, Tony?
No, I suppose it's just obviously this one of the departments that could advise or help or get involved with sort of setting up a real world evaluation. And I was just wondering where you were based and how you're structured. So I suppose it sounds like there's a bit of structure by trust, but also a bit of structure by sort of therapeutic specialism. Is that right?
So internally we do real world evaluations, and one of my specialties is real world drug evaluations, of which we've published quite a bit, particularly out of multiple myeloma, where we take a natural cohort and then see all these new and fancy drugs and see how well they're doing. Because clinical trial data is limited, and how clinicians actually use drugs that have been licensed is quite different to actually how they were developed. So we want to see, does this work or not? So I've got a reasonable amount of experience in real world evaluation in that context. And I can tell you that being an internal customer of OUH is just as hard and as frustrating and problematic as being an external one. We don't get any freebies, and it's almost as opaque for us internally from a departmental point of view as it is for an external person coming in. It's just like I've got my org chart who I can normally go and talk to a relevant person, and even then they might not know or actually understand. So there's that. Is that better?
Yeah, that's helpful. Thank you.
Yeah, if you need help reaching out to anybody, Tony, just give us a shout and we'll try and put you in touch with the right people.
Thanks, Ashley.
That's all right. Any other questions or?
Somebody is asking what's the best way to contact me after this meeting. At my work email address would be the best way.
Yeah, no, that's fine. So if that's all the questions, like my contact details are up on the screen at the minute. So if anything does occur to you afterwards, I know it's quite a lot of information to take in. You sometimes need a bit of time to digest. Feel free to send me an email. I'm more than happy to answer queries afterwards. Or if you've got any questions or queries that you'd like to put forward for the next webinar, which is really just going to be more of a Q&A session, maybe go into some of the questions that we've already had in a bit more depth, things like that. Feel free to send anything through. I'm sure Tony's got a couple. So yeah, and I look forward to maybe seeing you all next Tuesday.
Indeed.